the discussion will center around hypertension and stroke. To give more insights, we have with us Dr. Sameer Gupta, cardiologist who specializes in interventional cardiovascular and peripheral procedures. He completed his medicine residency at Penn State University, cardiology fellowship at the University of South Florida, and an interventional cardiology fellowship at the University of Chicago. In 2013, he was awarded the status of Extraordinary Ability and Achievement by the United States government. Dr. Gupta has authored multiple abstracts, journal articles, book chapters, and presented at multiple national and international meetings. The other speaker who will be joining us would be Dr. Sadiq Azam, currently working as consultant cardiologist at KIMS Hospital in Hyderabad. Welcome, Dr. Gupta.
Thank you so much for having me, Mr. Shankar. I think this is a
pleasure always. Yeah. So we'll start with the basics. What actually causes hypertension?
Yeah, so, hypertension has now become an epidemic in India. I know right now we are all concentrated on COVID, but hypertension is actually endemic and it's become an epidemic in India. Almost 30% of people in India have 30% of adults in India have hypertension. Now, first, what causes hypertension? I think it's also for the viewers to make them understand what is hypertension. Okay. So hypertension is the blood pressure is your blood pressure. And when your blood pressure is elevated, it is known as hypertension. Blood pressure is the pressure at which your body receives blood. Okay. So your heart beats, it ejects blood into the aorta, which is the main vessel of the heart. And then the blood is distributed to the entire body, to your brain, to your eyes, to your nose, to your mouth. All over every cell of your body gets blood. So the pressure at which that blood goes is called blood pressure. You check it with a blood pressure machine. It gives you two numbers, a higher number and a lower number. And if either of those two numbers are elevated, it is known as hypertension. Coming back to your question of what causes hypertension, there are many reasons why people have high blood pressure. The most common reason is you can divide them in two ways. One is genetic causes. So if there is somebody in your family who's got high blood pressure, your first degree relative, maybe your father, mother, your uncle, your aunt, your grandparents, then you have some genes that can increase your risk of high blood pressure. Then there are various other conditions because of which high blood pressure comes up. Thyroid diseases, endocrine diseases, like if you have, you can have steroid abnormalities in your body. You can have it because of kidney problems. If you have renal failure, you have a higher risk of hypertension. You can have it because of what we are seeing a lot of now today is because of diet and lifestyle related issues. The stress, lack of sleep, obesity, bad food, high salt intake. So a person may have one of them or a combination of these causes that causes high blood pressure.
Does smoking and alcohol also aggravate the situation?
Absolutely. So smoking is definitely a very important risk factor for hypertension. They say that after you smoke, your blood pressure remains elevated for a period of time, and chronic intake of nicotine, chronic intake of tar that you get from smoking can increase your blood pressure. Alcohol also has an increased risk of hypertension. This is not in solitude. I mean, it's not just one drink is going to cause your blood pressure, but if you consistently have increased amount of alcohol over a prolonged period of time, yes, it can increase your blood pressure.
Now, for a long time, 120/80 was the golden rule for BP readings. Then in 2007, the American Heart Association, the American College of Cardiology, revised the guidelines after 14 years to 130/80. Now in 2022, there are reports that 140/90 is also fine. So what's your take on this globally and with specific reference to the Indian population?
Yeah, so, so I think it's important to understand how we got these numbers. Okay, so 120/80 is your baseline, is your goal blood pressure. The closer we are to 120, the better it is for us. That does not mean that if you're at 110, you have to increase the blood pressure to 120. Some people live at 110, very good for them. That's ideal, right? So 120 over 80 is where we have to be. If you're at 110 without any blood pressure medicines, if you're at 105 without any blood pressure medicines, Mr. Shankar, a lot of people come to me and say, Dr. Gupta, my blood pressure runs low. Mera BP kam rehta hai. Especially these young women, college girls, they say, I have low blood pressure, my blood pressure is 100. So that's not to be worried about. If you're not dizzy, lightheaded, that's not to be worried about. Young people can live at a low blood pressure. So there was this very big trial. It was called the SPRINT trial. And what they did was they said, so let me add one more thing. So 120 over 80 is where we have to live. The closer we are, the better it is. The definition of hypertension was 140 over 90. So between 120 to 140 was kind of the pre-hypertensive / gray zone. And if you're above 140, the top number, 90, the bottom number, then you're diagnosed as hypertension. That is what we practiced for many, many years. So then they came along this trial in 2017 called the SPRINT trial, and they questioned the dogma. They said, is 140 over 90 is what we call hypertension. But what if you go down to 130 and the bottom number of 80? What if we try and achieve that number with medicines? So if you are on medicines and your blood pressure is 135 or 138, what if I get it closer to 130? Am I going to derive significant benefit? And the answer was yes. So that means the closer once again you get to 120 over 80, the better it is. It kind of reaffirmed our diagnosis, reaffirmed what we already knew. But it was important for us. This was a very important trial because it really changed the way we thought about treating blood pressure. So now in most patients, we try and reach a goal of at least 130 over 80 because that 10 millimeters that we were missing was giving us incremental benefit in reducing mortality, making you feel better, and more importantly, making you live longer. I hope I was not too scientific when I explained.
No, not at all. Did the SPRINT trial include populations like from India and Asian populations also?
So I don't remember the exact breakup of the SPRINT trial, but what the SPRINT trial did show, it's different sides of the pond. The Americans still go at 130 over 80. The Europeans feel 140 over 90 is kind of okay. Now, India, when we say that India has 30% of hypertensives, that's with the old definition of 140-90. If we go down to 130 over 80, this number of 25% will certainly increase. There are some studies out there which say that they'll go up to as much as 45-50%. So I'm not really sure if the Indian population was there or not. But given the fact that heart disease and cardiovascular disease is so rampant in India, I'm inclined to achieve a goal of 130 over 80 as compared to 140 over 90.
Now, if there is a person who is in 135 or close to 140 or even 130, do you have any medical intervention, or you say that you manage by diet and exercise to bring it down to 120?
So when you are in that zone of between 130 to 140, right? So with the new definition of hypertension, they said if you're between 131 to 140, and your diastolic is between that 80 and above mark and below 90, that time they diagnosed you with hypertension, but they said this is the point where you should really try and improve your diet, improve your lifestyle, start making changes, and start becoming more healthy to reduce your risk of hypertension. And trust me, many patients are able to kind of go from that hypertensive stage to normotensive stage where the blood pressure is consistently below 120/80. Now, it's also important not to go on an isolated reading. For 100% of my patients, I do not treat them with one number. I tell them, show me a trend. Let me see what 4 or 5 numbers are. I get ambulatory blood pressure monitoring on them, which is a machine which measures your blood pressure for 24 hours continuously. Every half an hour or so, it checks your blood pressure. So we always treat a trend and not an isolated number.
So you also have this white coat hypertension. When people meet you, they have hypertension.
Yes.
Well, my other question is, does hypertension vary with age?
It does. It does to a certain extent.
So what should be the reading for people who are above 50, and what is the calculation that you have?
So no. So to answer your question is that are the cutoffs different for different age groups?
Yeah.
The answer is no. So we don't use a different cutoff for different age groups. It's not that, for a 20-year-old, 140 is hypertensive, and for a 70-year-old, 140 is normotensive. No, we don't do that. The definition of hypertension remains unchanged. We treat you for that number. We may treat you less aggressively or more aggressively. That depends upon the individual discretion of towards that patient and towards the entire thing. But the definition of hypertension does not change with age. That number of 120 over 8, the number of 130 over 80 or 140 over 90, whichever your physician is practicing, that remains unchanged.
Quite often people tend to dismiss hypertension as stress. Is that true?
Yes, people do that, Mr. Shankar. A lot of people do that. And, I think it's important to understand what your body is doing. Now, yes, absolutely. If you're in a stressful situation, if you are fighting with someone, if you're under a lot of mental stress, emotional stress, work stress, whatever that stress may be, or like many of my patients say that, doctor, every time I watch the news, my blood pressure goes up because I don't like what's happening. In those cases, yes, your blood pressure can go up. But it is important when you check your blood pressure. When you check your blood pressure, you should be sitting comfortably on a chair. Okay. Check your legs not crossed. You should be sitting comfortably on a chair. Don't cross your legs. Sit down quietly for a few minutes and then check your blood pressure. That is your right blood pressure. What ends up happening is that people are very stressed, very angry, and then they check their blood pressure and the blood pressure is high. And then because the blood pressure is high, and then they get even more anxious and even more stressful. So yes, that is definitely concerning if your blood pressure is reaching sky-high limits under conditions of stress. But an isolated reading of 140 over 90 when you're fighting with someone, arguing with someone, is not something which is totally uncommon.
You've worked considerably in the US, and it is said that the Caucasian population have larger blood vessels compared to the Asian population, especially Indians. Why is it that so? And does this make interventional peripheral procedures a bit risky and also tough?
So yes, I was there for many years. I practiced over there for many years, and one thing, this is something which is kind of debatable in the medical community, that do Indians have smaller coronary arteries compared to the Western population? Now, because there are various reasons why that determines the size of the coronary arteries. There are some genetic reasons, but there are also body physiques. People in the Western world typically are taller. They are a little bit more well built. People in Southeast Asia are typically, shorter. When they gain weight in India, they gain more of centripetal obesity. That means, everybody has a paunch. Mostly in the Western world, when they gain weight, that weight is wholesome. It's like at the hips also you gain weight. You may gain weight on the chest also. In India, that's usually not the case. And that has to do with genetics. So there are a lot of genetic variabilities that determine a lot of factors. Coming back to your core question, does Indians have coronary arteries? Comparatively, I would feel yes. From my personal anecdotal experience, I would feel they do compared to the Western worlds. That is on a case-by-case basis. And does that make coronary interventions a little bit more challenging? Well, I think it all depends upon your skill set. I don't think it is just this one thing which makes it challenging. I would say that Indians have a lot more heart disease compared to the Western world. This has been proven in literature that Indians get heart disease almost 10 years earlier than the Western counterparts. In India, if you talk to any cardiologist, and I'm sure Dr. Azam, when he comes in and he gives his opinion, it is not uncommon to have 30-year-old, 40-year-old, early 50s with all three vessel blockages, really severe disease, as compared to the US, where, if somebody had come in their 20s with heart attack, it was very, very rare. In India, it's not at all rare. In fact, 25% of all heart attacks happen in people who are less than 40 years age.
So the related question is, do people who have smaller blood vessels stand at greater risk of having a hypertension?
I don't know if the smaller coronary arteries by itself increases your risk of hypertension. What we do see is that those people who have chronic hypertension, if they have chronic uncontrolled hypertension, then we do see some things in the coronary arteries which make us think that this person has had hypertension. We see a lot of curliness, we see a lot of tortuosity in the vessels. That makes us think that this person has had chronic hypertension. But I don't think that chronic hypertension can lead to smaller coronary arteries, if that was the question. Now, if you have chronic hypertension, you have a higher risk of blockages in the arteries of the heart. Right? So there's a higher chance of you having blockages, but I'm not sure if that can be completely correlated with smaller size of the coronary artery.
Come back to Dr. Gupta. I'll now move on to, I'll have a second round of questions, of course. I'll move on to Dr. Sadiq. Dr. Sadiq, welcome. Can you unmute yourself, Dr. Sadiq?
Yes, sir. I'm here. Yeah.
Good afternoon and welcome. I'm glad to see you again from Hyderabad.
Thank you. Thank you for having me again, sir. Thank you. It's always a pleasure.
I hope it is raining in Hyderabad. Your hot season is over.
Yeah, it's raining now.
That's good. That's good. Now, Dr. Gupta did set the ball in rolling. So I'll ask you, why are more youngsters falling prey to hypertension and cardiac ailments?
Well, I think lack of activity is probably one of the major causes that we are seeing in the last couple of years, especially since, this whole pandemic took over and people were forced to stay indoors. A lot of people, we as doctors were probably the only people on the roads at that time, allowed to be on the roads at that time, probably the right thing to say. A lot of people lost the habit of exercise. A lot of people lost the habit of regular physical activity. You were indoors, you was confined to your thing. And not a lot of us actually, even people who used to do regular exercise prior, used to probably go to gyms, go to parks. Not many people used to, do kind of exercise at home. And now that we are more into this apartment culture and confined living spaces where you don't really have the good old days when, you had a house with a balcony, or, you have a terrace, or, a garden where you go and walk. And most of us are living within a 2 BHK, 3 BHK, where you don't have the luxury to have a specific exercise area. People just, took it as an excuse to reduce their physical activity, become more sedentary, and then easy access to food delivery apps. Now you're eating more and you're working out less, and you're eating a lot of junk. And you want to eat junk, it's there at the snap of your finger. Within 30 minutes or less, you have it at your doorstep. So this wasn't happening before. Now there's a lot of change in our own diet, our own lifestyle, and that has probably set the ball rolling to many more youngsters coming in. As Dr. Gupta was rightly saying that, a lot of times we are seeing patients coming in with young heart attacks, late 20s, early 30s, people with massive MIs. They seemingly don't have any risk factors, yet when they come in, we find their pressures are 170, 180. People who have come with strokes, intracranial bleeds, who have high blood pressures of 170, 180, close to 200 even at times. People who, your morbid obesity. The pandemic has led to a lot of sedentary lifestyle, increase in weight. Obesity has contributed to sleep apnea, which is one of the underdiagnosed, even today, one of the most underdiagnosed risk factors for development of young hypertension. In fact, since we actively started looking into sleep apnea in young hypertensives, we are surprised almost 4 out of 10 patients that we looked at in young hypertensives turned out to have some degree of sleep apnea. And these are people who actually do well with lifestyle changes, with the use of CPAP for some time. Their weight comes down, their metabolic syndrome reverts, and then their pressures get controlled. So these are people who probably, if you identify them early and treat them early, change their lifestyle, they come down to a healthy weight, they come down to a healthy build, and they have regular exercise, regular diet. These are the population where you can actually reverse the high blood pressure, rather than, when compared to an elderly whose vessels have already stiffened, the heart has already remodeled. They are people who will be on drugs for life. So that is probably one of the major reasons why we are seeing a spurt in young hypertensives.
Hypertension is described as a silent enemy. How early can hypertension be detected, and what are the symptoms?
Hypertension can be detected the thing with hypertension, the reason why it's called a silent killer is close to more than 50% of people who have hypertension don't have symptoms. And unless your pressure crosses 170, 180, 200, when you're developing, signs like headache and occipital, early morning headache, early morning giddiness, people at towards the stages might even come with ocular symptoms, blurring of vision, blackouts, giddiness, falls. Sometimes they can have palpitations, irregular heartbeats. Now, these are the people that you end up detecting. But otherwise, people who have pressures 140, 150, unless they actually go and get it checked, you're not going to be able to detect it. So I think at least in today's day and age, everybody should have a BP apparatus at home. And maybe once a month, you just check all your pressures, because especially if you have risk factors, especially if you're living a sedentary life, if you are a diabetic, if you are a smoker or you have ever smoked, if you're around people who smoke, if you consume alcohol on a regular basis, now if your cholesterols are high, if you are on the higher obese side, or even on the little more of a heavier weight, you should probably be looking at your pressures every month and look at them in both your arms, not just in one arm.
You were saying that it is better to have it checked at your home. How reliable are these gadgets that are now in market?
Surprisingly quite reliable, because over the pandemic we have seen there has been a lot of spurt in small town industries and stuff, where pressures have BP apparatuses and pulse oximeters, and a lot of these gadgets have become more freely available to the public, and that has also helped in driving down the cost. Today you get a self-monitoring BP apparatus for somewhere around 600, 800 also. And but of course, stay away from things that are too good to be true. If it's something is too good to be true, it's probably not true. That is the dictum. So if you're getting a BP apparatus that should minimum cost you 800 rupees for 100 rupees, I would take it with not just a pinch of salt, maybe a fistful of salt. So don't try to go for the best deal always. Look at, there are standard brands available in the market, and anything of your choice you can pick. What I generally tell my patients is, you know your standard blood pressure in the clinic, have a comparison with your pressure at home. But again, this doesn't really help because of the concept of white coat hypertension. See, somebody might be normotensive at home, but they come to the hospital, their pressures are high. So that's what white coat hypertension is. It doesn't necessarily mean if I check the pressure, even if my nurse, my assistant, somebody checks the pressure in the hospital, it might still come high. So home BP, there is something known as ambulatory BP. In people in whom we feel that, it's not really correlating the pressures that the machine is giving versus the pressure that the patient is telling us. They're not really correlating. We get this ambulatory BP recording, which is a much more robust tool for assessing patients with hypertension. And in fact, some of the guidelines have said that before you start somebody off on antihypertensive therapy, when your pressures are borderline, or when you're having a strong suspicion of white coat hypertension, it's always better you do an ambulatory BP recording before you start them off. Now, this helps you in planning treatment. It helps you in identifying people who have just spikes, early morning spikes, people who have nocturnal spikes, people who have dips in their pressures. So it also helps us to titrate. But then again, it's not a tool for everyone, for every patient. I would not recommend it. But yeah, that's also a good thing. And these machines which are available are fairly reliable, and I think that it's a good place to start.
Now, there is robust evidence that screening and treatment of hypertension patients prevents cardiovascular disease and reduces mortality in the middle-aged population. Even in older adults, lowering BP is likely to be beneficial, provided the treatment is well tolerated despite a lack of studies to support this. What's your view?
I'm sorry, I didn't get to the last part.
I said even in older adults, lowering BP is likely to be beneficial, provided that the treatment is well tolerated, despite the lack of studies to support this view. What's your viewpoint?
Well, sir, there actually are a lot of studies in the elderly population as well. As Dr. Gupta was rightly speaking about the SPRINT trial, which had a very major impact on our practice today, which conclusively showed that event rates by reducing the pressures less than 120/80 were significantly lesser when compared to people who had pressures more than 120/80. Now, one caveat in that was that when you looked at the older population above 75, it was found that if you reduce the pressures too aggressively, that is, you bring them down to 120/80 very aggressively, then there was a slightly increased risk of falls in this population. So in people above 75, we can maybe even accept pressures around 130 to 140 in that range. But in people lesser than 75, you have every evidence to say that the lower the pressure, less than 120, has to be your target. Now, there have been a lot of other studies. There was HOPE initially, there's HOPE 3 now, which has also shown that lowering blood pressure does reduce events. So even whether it is elderly, whether it is young, you have to reduce. But one thing you have to understand is that never try to reduce it too aggressively. Like somebody who is having a pressure of say 180, 100, and you have been seeing him at a pressure of 180, 100, all of a sudden you start him on 3 drugs, 4 drugs, and his pressures drop down to 100 by 60, or 110 by 70. That itself can be deleterious. So it has to be done over a period of time. In fact, in the first 24 hours, also in patients who come with hypertensive emergencies, their pressures are say 200. We are happy if it comes down to 150 or 160. We will not try to bring it down to 120 just at the drop of a hat, even though with drugs you can do that. But you want to bring it down more gradually. But this is because of one thing that they say, that even though our brain's blood supply is auto-regulated, at these high pressures, there is some, there's a postulate that auto-regulation tends to fail at persistently high pressures. So if you drastically bring down the pressure from 200 to 100, you can cause ischemia to the brain, which might lead to a stroke. So you bring it down, but bring it down gradually, unless, of course, the patient has had a bleed. If the patient has had a bleed, then you have to bring it down drastically, because there, the higher the pressure, the more your hematoma is going to form. So otherwise, we have to bring pressures down, whether it is elderly or whether it is a young patient.
The underlying factor is that it should be brought down gradually.
Brought down gradually, and in the elderly, maybe you don't want to target 120. Probably even 130 or 140 is fine in somebody who is above 70. But below that, yes, 120 has to be the target.
Yeah, we shall now focus on hypertension and stroke, and I'll come back to Dr. Gupta. Please stay on, Dr. Azam. I'll come back to you. Dr. Gupta, how can hypertension actually cause stroke? What's the mechanism?
Yeah, so when you think of stroke is basically of 2 broad types of strokes. One is what you call ischemic stroke, and the other is called hemorrhagic stroke. Ischemic stroke is when there is a blood clot which gets formed in the artery of your brain, and you get a stroke. Now, the blood clot can be formed because there is plaque over there, or there's a blood clot which came from some other part of your body, usually the heart. So that is what you call ischemic stroke. These blood clots can happen, these blockages can happen because of high blood pressure. These blockages, where it plays a very important role in the formation of blockages. It can happen because of atrial fibrillation, which is an irregular heart rate. That is also, hypertension plays a very important role in causing it. And there can be other causes of small vessel stroke because of high blood pressure. The other is the hemorrhagic stroke, where there is an artery in your brain that bursts, and it can bleed into your brain and cause a stroke, what you call brain hemorrhage. So chronic hypertension can weaken these arteries sometimes. An acute, very high blood pressure, like Dr. Azam said, it can also cause that artery in your brain, a small artery in your brain, to burst and cause blood to leak. So that's how you can have hypertension with stroke. Now, ischemic stroke, the one where blood clots get formed in the arteries of your brain, that's definitely more common. 80% of all strokes happen because of that mechanism, and 20% of strokes are from brain hemorrhages.
Now, what exactly is hypertensive stroke?
So when you think of hypertensive stroke, it encompasses both of these things, more so of the former type of the ischemic stroke, where you have high blood pressure for a long time and then you can have a stroke. You can also have a hypertensive stroke when you've had chronic hypertension for a long time, and a small part of your brain can have a small little bleed over there, or a clot can form in a very small area, and that's usually what you call hypertensive strokes.
Now, can hypertension cause if there is a pre-existing aneurysm, can it cause the rupture of aneurysms if you have high blood pressure?
Yeah, so I'm guessing the audience for this is the common man. So let me first tell you what an aneurysm is.
Aneurysm is, yes.
Right. So an aneurysm is anytime there are artery of your heart, any artery in your body, you can think of it like a cylinder. Okay, like a cylinder. Let me put it like this: like a cylinder, like this, like straight like this, right? It may be a little curly, but for the most part, these two angles are like, they'll be parallel to each other, the two sides of this. Now, when you have an aneurysm, your artery balloons out. So a part of your artery balloons out. So it may become like this. So over here, if you see, there is a little bit ballooning, and in the top, it becomes straight again. Okay, so it balloons out. This ballooning is called an aneurysm. The ballooning of a vessel is called an aneurysm, where the artery basically dilates in a small to a large portion of the vessel. These aneurysms can form anywhere in the body. They can have brain aneurysms. They can cause strokes. You can have aneurysms in the arteries of your coronary arteries of your heart. You can have it in the aorta. You can have it in many other places. Okay, hypertension is a very important cause for formation of these aneurysms, because chronic stress at high pressure can cause the vessels to dilate, the vessel wall to weaken, and the vessels start ballooning out. Now, when you have high blood pressure, because the vessels are weak, the vessel wall has become weak because of high blood pressure for a long period of time, or because of other causes also, but I'm just using hypertension as an example. When you have very high blood pressure all of a sudden, or you are that time, this weak vessel wall can burst, or it can cause dissection, what you call. So it can cause aortic dissection, it can cause aortic rupture, perforations of these arteries. So high blood pressure not only causes this, but also acute elevation of blood pressure can cause them to burst.
Now, is hypertension and stroke more common among men or women, or is it equally divided?
It's definitely men. It's more common. Both hypertension and strokes are more common in men. There are various reasons for that. There's also a school of thought which says that it's probably prevalent in women also, but it's not picked up as often in women. So that's also a thought. But as of now, statistically speaking, men have more hypertension, men have more strokes, men have more heart disease. Now, women also, because of the hormonal things with women, they're kind of protected from hypertension, at least till they hit menopause, right? Till they hit menopause, there is a certain element of protection that women inherently get from nature that puts them at a lower incidence of hypertension. However, it's not that premenopausal women are not hypertensive. They can definitely get hypertension, but there's a certain element of inherent protection they have.
So there was also a recent study which said that over 80% of the women who are hypertensive are also obese. So what's the link?
So, obesity definitely increases your risk of hypertension, whether it is men or women is relevant. Okay. Obesity increases your risk of hypertension because when you're obese, you have more mass in your body. And when you have more mass, that mass needs blood. It needs oxygen, right? The fat cells need oxygen. And it increases what you call vascular resistance. So that can cause it increases the risk of hypertension. Also, there are certain inflammatory markers that are secreted from obesity because of obesity that can increase your risk of hypertension. So I think there are a multitude of factors that cause this. And also, if you see who are the people who are obese, right? Whether it's men or women, those people who are eating, who have a bad diet, those people who are not exercising, those people who are not sleeping enough, those are the people who have obstructive sleep apnea. So it's a multitude of things together that can cause hypertension in this subset of people.
Okay, I'll come back to you, Dr. Gupta. I'll move on to Dr. Sadiq once more. Dr. Azim, how is hypertension managed, especially in acute phase of hypertensive encephalopathy, ischemic stroke, and hemorrhagic stroke? I know it's a bit technical, but you can explain it in layman language.
Well, sir, see, these things that you're talking about, they are called as hypertensive emergency. So, hypertensive emergency is something which is not characterized by the level of the blood pressure alone. Like, for example, there are two patients, both have a pressure of 200 by 100. One might be an urgency, one might be an emergency. So, for blood pressure, we have certain organs that we look at. One is the eyes, your heart, your kidneys, and the brain. So these are the four end organs that you say. Now, whenever there is high blood pressure associated with involvement of any of these four end organs, That is either there is a patient with high BP with chest pain with ECG changes, or there is a patient with high BP with a stroke, or there is a patient with high BP with changes in his retina, or there is a patient with high BP with increased excretion of protein in his urine, what we call as proteinuria. If any of these things happen, it is taken as a hypertensive emergency, which becomes an indication for you to admit the patient, and it has to be managed in an ICU setting involving intravenous drugs. So we have IV drugs like you have nitroglycerin or nitroprusside, or there was a time when we used to use enalapril to reduce the blood pressure. Now, in majority of these things, other than a hemorrhagic stroke, your target is to reduce the pressure gradually over a period of time. So initially, we probably will reduce it by maybe 20% over the first 6 hours, and then so on and so forth. Somebody who comes with, say, 210 BP, many times, patients say, doctor, we came with our pressure was 200 and now it is already 1 day. Pressure is still 150, 160. Abhi tak, why haven't you made it normal? See, you have to understand that if we bring it from 200 to 110 within 12 hours, it's very likely that a patient who doesn't have an ischemic stroke will develop one. This is because there are certain areas in the brain known as watershed areas where there is a high risk of developing, lacunar infarcts, and minor strokes can occur because of too aggressive control of pressures also. So if you're a patient who has been admitted with, a very high BP, and you find by the next day your pressure has only come down by 50%, that's okay. You don't have to panic. You don't have to think that, what are the doctors doing? Why have they not controlled my pressure? Are they trying to keep me longer for the ICU? Don't think of such things. What is being done is, as per the standard recommended protocols, gradually bring down your pressure so that you're at target over the next 24 to 48 hours. Now, if there is a bleed, as sir was saying, somebody who has an intracranial hematoma, which is around 20 to 30% of strokes have this intracranial bleeds, which can occur because of the rupture of an otherwise asymptomatic aneurysm, which can occur without, even a patient having an aneurysm. It can occur when somebody's pressures are high, or when they're on blood thinners. There are many causes for it. Now, this is one condition where you want to bring down the pressures aggressively within the first 24 hours itself. This is because having a high pressure head in such patients can cause the development of further increase in size of the hematoma. And if there's too much of pressure built up inside your skull, the brain can come down, and that is something known as a herniation, which can even become a terminal event. So in these patients, you try to reduce the pressures more aggressively, whereas in other things like an ischemic stroke, you try to reduce it more gradually. Now, if there is a patient who is having a heart attack, along with a heart attack, he has high blood pressures. Now, in these conditions, it depends on what the plan for the patient is. For example, you're planning to thrombolize the patient. You give him an aggressive high dose of a blood thinner. In such cases, having a very high pressure, maybe more than 160, 100, is not something that you would want to do. So you would want to bring down the pressures a little bit by giving some intravenous drugs, and then you can go ahead with your treatment. Patients who are, but you have to be very careful when you're giving antihypertensive drugs in an acute heart attack, because the acute heart attack itself can cause drop in pressures eventually. So if you give drugs like, you give oral drugs which will bring down the pressures gradually, and their action lasts for more than 6 hours, 8 hours, and then these patients develop low BP as a consequence of their heart attack, then you have to start IV drugs to increase their pressures. So it's probably better to give shorter acting intravenous agents like nitroglycerin or nitroprusside, which you can take off immediately, and their action subsides and the pressures can normalize in case the patient has a hypotensive event. So now, if there's somebody who comes in with high blood pressure but doesn't have any of these end organ involvement, ECG is normal, neurological examination is normal, fundus examination doesn't show any papilledema, no retinal changes, then you can probably give the patient oral agents. We generally prefer to give either amlodipine or an ARB, and then observe the patient over the next 12 to 24 hours. The pressures will gradually keep decreasing when you can up titrate your drugs as and when necessary. So this is how you treat an acute hypertensive emergency or a hypertensive crisis.
Now, roughly, what is the percentage of young population facing the risk of stroke due to hypertension?
Well, sir, young population, young hypertensive itself, if you look at conventional data, they say that there are around 10 to 15% of people who are young hypertensive. But now we are seeing a lot more people who are presenting with hypertension in the young age group. So rather than young or old, it depends upon how well controlled your pressures are for you to calculate the risk of stroke. So whether it is a youngster or whether it's an elderly person, if your pressures are uncontrolled, then you are at a significant risk of stroke. It might even be if somebody is, say, for example, pressures are more than 160, 170, then your risk of stroke is on the upper side of 50%.
Now, I'll move on to Dr. Gupta with one question, and then I'll come back to you, Dr. Hassan. What is cryptogenic stroke?
So cryptogenic stroke are strokes when you don't have a clear reason for it. Okay. So, you normally when somebody has a stroke, we try and find a reason for it, right? So you can try and treat the underlying cause, whether it is embolic stroke, whether it is a hemorrhagic stroke, you try and find a reason for it. So those strokes where you don't have a clear etiology of it is what you call a cryptogenic stroke. Now, when you have a cryptogenic stroke, there's an extensive workup that we do, right? That is there a blood clot? Where did the blood clot come from? Are there any tendencies any genetic tendencies for blood clotting that the concerned patient may have? You do an extensive workup. So if you don't have an exact reason or etiology for the stroke, it is what you call a cryptogenic stroke.
Now, can we use some modern methods like artificial intelligence and other areas to catch hypertension early on?
So I think hypertension. There are various ways in which you diagnose hypertension. Right. The first and foremost thing you do is it's actually very easy to diagnose hypertension. All you do is get a blood pressure. Right.
Yeah.
You go to your local doctor. You go to your pharmacy. You go to your work. Nowadays, a lot of people have the health rooms in the corporate offices, and there's a blood pressure machine over there, and you just check your blood pressure, and you know if your blood pressure is high or low. If your blood pressure is high, which is like we talked about, 130 over 80, or if it's definitely over 140 over 90, for sure you have hypertension. So if your blood pressure is in that range, then you have a hypertension, right? So I don't know if AI would be actually useful in diagnosing hypertension. You will have to diagnose it by a blood pressure cuff. Now, can we try and predict who is going to be hypertensive? Yes. That is where AI may come out to be helpful. For that, you would need large data sets. You will need a lot of more information. A lot of things will have to be fed in. So you can try and predict a person's risk of hypertension in his life. I will tell you one more thing over here. There's been a lot of talk about the polygenic risk score in diagnosing heart disease or giving a risk of heart disease. But all these, so hypertension, diabetes are what we call lifestyle disorders, right? That yes, there is a genetic component to it, but lifestyle plays a very important role as well. Okay, there is a certain genetic component and there is a certain lifestyle component. So it's two things together which make you hypertensive. It's two things together which make you diabetic, etc. Some of the other lifestyle diseases. It's not one or the other. Now, there may be only genetic causes which make you diabetic, right? There are some cases of that, but I'm talking about just a broad overview. So it's a little bit of one, a little bit of the other. Together, it increases the risk of hypertension. So to answer your question, can we use AI to try and predict who is going to become hypertensive? Yes, there may be an option. You need a lot of data. You will need a lot of information. But I think the simpler task is just go to your local doctor, get your blood pressure check, and you have a diagnosis.
Do you also have cases of kids having hypertension?
So I don't normally see kids. I'm more of an adult doctor. However, I know of children who get hypertensive. It is becoming an increasing problem in the pediatric population. Now, there are various reasons for kids becoming hypertensive. The reason for a 1-year-old will be very different from that of 18-year-old who gets hypertensive. When you're in the 1 to up to, I would say, 12, 13, 14 years of age, Important reason of hypertension is genetic causes and hormonal issues and cardiac issues, etc., which can cause hypertension. As you go in your late teens, that's where the diet lifestyle starts coming into the picture, apart from the other secondary causes of hypertension like hormonal issues, obesity, and endocrine disorders, kidney issues that can cause hypertension. So I think and also the definition of hypertension in this age group is different. What you would call a hypertensive for a 1-year-old or for a 6-month-old is going to be different from that it is going to be when you're 17, 18. So the definition of hypertension changes, the cutoff values change.
Yeah, we'll be running short of time, but I have a common question to both you and Dr. Sadiq, and that is, has COVID, especially long COVID, changed the entire scenario of hypertension and stroke? Yes, Dr. Gupta, you can answer, and then followed by Dr. Sadiq.
Sure, yeah. So I think COVID has definitely changed the paradigm of health in general. I wouldn't say just hypertension and stroke, but the entire paradigm of health has been changed. People have become, I feel, for the most part, more health conscious. They've become more health aware. They want to take the right things. Health insurance has shot up. People who are now going out and actively getting health checkups has certainly increased. At least that's what I feel, compared to what it was pre-pandemic, when health was kind of taken for granted and people were, not paying too much attention to it. So I think that has definitely happened. As far as hypertension per se is concerned, I did see a higher incidence of hypertension during the COVID era. There were multiple reasons for that. I think people were not paying that much attention to the diet. They were sitting at home and they were eating a lot of junk and chips and all that good stuff. They were not exercising that much. Stress was a very important thing that was happening, both mental and emotional stress. Whether it was a lot of people lost their jobs, they were in stress for that, financial stress, loss of family during the second wave, first wave, during this entire time. So I think that also caused a high blood pressure and increased incidence of hypertension during that time. Now, obviously, things are better. Everybody's out and about. So I think hypertension has, maybe taken a back seat as far as getting themselves checked is concerned.
So, Dr. Sadiq, what's your message on this?
Yeah, as Dr. Gupta was so rightly saying, COVID has changed a lot. The entire paradigm of healthcare, the paradigm of disease spectrum of diseases that we are seeing, heart diseases that we are seeing, hypertension, increased spike in hypertension, and basically a lot more lifestyle diseases have, there's been a surge in all of this post-COVID. Not only this, the challenges for us as physicians managing these patients, that has also increased. But there's a lot of positive things also that have come in. People have become more aware of their health. People are taking more initiatives to actually try and learn more about disease. Yes, there is always been the demon of misinformation, and that was always there. And probably to some extent it has been quelled because a lot more people are now actually trying to do their own research, which is a very good thing. And they're not just blindly believing things that are being heard, things that are being said, which makes our job easy to a much greater extent, because a patient who is motivated to understand their disease, motivated to understand what is going wrong with them, is probably much better placed to have benefit from the strategies that we tell them. For example, like today, I just saw a patient who was around 40 years of age, never been a hypertensive. He has checked his pressures recently and he's found that his pressures were around 140/100. So when I was speaking to him and telling him that, he should probably try a good lifestyle modification strategy first before I start him off on drugs, he was actually very receptive and very understanding of the whole thing. And he's ready and very motivated to improve his lifestyle. He himself says that he used to walk around 3 to 4 kilometers previously, but for the last 1 year, he has not been doing activity. He's become more sedentary. He's eating more of fast foods, and he's been working from home. So he is motivated to start a good exercise regime, to modify his diet, and we'll see how he does in the next 15 days or a month. If his pressures are not controlled, we'll go on to drugs. But what I'm trying to say is that this type of awareness that has come in people have actually realized that their health means something. People, we probably started taking our health for granted. Especially, we as doctors are probably equally to blame in that, because we take our own health for granted many times, and probably that's something we should not be doing. Everything that we tell patients to do, we should start doing ourselves as well. Not only us, everybody, every professional, we have this feeling that, Arey yaar, hamare saath nahi hoga. This will not happen with us. This is not a disease that will affect us. That is the biggest mistake that you can ever make. Don't ever think that, this disease will not happen to me. I will never have a heart attack. I will never have a stroke. God forbid you do, then you need to be prepared for it. You need to try, at least, if you're destined to have something, it might happen, but you should not invite trouble before it's time. So don't.
Very true.
Try to have a good.
Very true. I think prevention is much better than.
Yes, definitely. And one more thing, sir, we were just discussing about hypertension in children. There's one interesting case that, for awareness, I thought I'll just say. One of my colleagues, he found that there was a child around 7 or 8 years of age who came with hypertension to his clinic. And as sir says, there are causes at different ages which can affect children. So he did the usual workup. And after doing the entire workup, everything came negative. So when he went back and he asked the drug history from the parents, is there something that you're not telling me? So they said, no, there's nothing. Child has been perfectly fine. It's just that, she has chronic cold. So we keep giving her cough syrup. And the child has been on cough syrup for 1 year. Now you have to understand that these cough syrups contain something known as phenylephrine, which is a vasoconstrictor. Now, when given for a short period of time, it causes vasoconstriction in the blood vessels. So it reduces stuffy nose and other things. But the same thing when given for a long time, like this child was taking it for 1 year, it can lead to hypertension also. So don't go with over the drug therapies. People have this habit, especially in our country, where drugs are not that regulated. You don't need a prescription in majority of the places. You can walk in and the pharmacist will tell you what drug you need to take. So a lot of this over-the-counter things have been happening, and that is also a cause why people develop hypertension, because side effects are also something which is real. So don't take drugs which are not necessary. At the same time, do take drugs which are necessary. And hypertension is one thing that should be controlled. Once BP is controlled, patients have to think, we leave our medicines. Hamara BP treat ho gaya, cure ho gaya. See, blood pressure is like driving a car. Keep your hand on the steering, you won't meet with an accident. You think Gadi is going straight, I will leave the steering wheel, you will have an accident. So drugs, lifestyle have to be there for the rest of your life.
Wonderful message, Dr. Sadiq Hassan. And many of the people leave the steering wheel, leave the handle of the motorcycle also, thinking that the road ahead is safe for them. But you know what happens. Thank you very much. It was a wonderful session with both Dr. Gupta and Dr. Sadiq. Wonderful having you on our session. Thank you very much.